Bismillahirrahmanirrahim. I am Dr. Inam Beg, a respiratory physician and a clinical educationist, currently working in the United Kingdom. My previous background is that I served in the Army Medical Corps of Pakistan for 25 years until 2014. Through this video, I would like to talk to healthcare administrators, hospital managers, and especially finance managers in developing countries like Pakistan in context of the COVID-19 pandemic. Now, in the recent months, we have all heard about the need of ventilatory support, and ventilators are now so commonly talked around in the whole world. Indeed, among all those who have died so far, more than 280,000 individuals on the surface of the earth, we know that many of the fatal cases received ventilatory support. However, what is less talked is that there is a non-invasive ventilation as well. And that's what we are going to talk today, because most of the focus has remained on mechanical invasive ventilation. In addition to the hospital or healthcare administrator, this talk can be useful to healthcare professionals, including non-specialist doctors, medical students, or other associated healthcare professionals. So the main idea is to talk about some non-invasive ventilatory supports which have been found beneficial in the last couple of months when they were used in countries like United Kingdom, Europe, and before that they were used in China as well. Why we use ventilators in COVID-19 related respiratory problem? Because here we are dealing with severe pneumonia, ARDS, and other possible mechanisms like pulmonary embolism, microangiopathy leading to this respiratory failure. In the critical care settings, some other mechanisms have been seen, possibly taking patients to the fatal outcome, and that is severe renal failure, many people requiring hemofiltration, hemodialysis while being on the ICUs. So there are many more things in addition to respiratory failure which might be causing, which might be contributing to the fatal outcomes. However, today we are going to focus ourselves to the respiratory failure part. What is respiratory failure? Just simply trying to inform you without using much of medical terminology. I would like to say that respiratory failure means that either there is a problem of oxygenation to our body, that oxygen is not being supplied in enough quantity, normal quantity to our cells, organs and tissues, or in addition to that, the carbon dioxide is also being retained inside the blood. So we have got now two types of respiratory failure. The type 1, in which there is low oxygen, which is called hypoxemia. So when the arterial blood is measured for the level of the oxygen, we find that the oxygen levels are low. And wherever there are possible, when they measure the arterial blood gases, the oxygen level being less than 8 kilopascals is called respiratory failure, although the normal levels should be, according to the different ages, they should be between 10 and 14. However, the cutoff line is 8, so 9 would be still hypoxemia, 9.5, 10 would be hypoxemia, but not really respiratory failure. So respiratory failure would be defined from 8 or 8 downwards. And this is the main problem. The type 1 respiratory failure is the main problem in COVID-19 related pneumonia, ARDS. However, in some patients, we have seen type 2 respiratory failure, which means that there is low oxygen in the blood, as well as the level of carbon dioxide rises. So the normal should be less than 6 kilopascal, but it rises more than that. And then accordingly, you can say that it is a severe hypercapnia, severe raised carbon dioxide, or moderately raised, or mildly raised. And when there is low oxygen as well as high carbon dioxide, we call it type 2 respiratory failure. So why we have respiratory failure as the main problem in these COVID-19 sufferers, as we already said, that it is because of pneumonia involving both lungs, severe pneumonia, extensive pneumonia, and it further leading to a condition called ARDS. What happens is the alveoli, where there is a respiratory membrane, and from where the oxygen gets transferred from the lungs into the blood, becomes filled with exudate, with inflammatory material, and it becomes difficult for the oxygen to pass into the blood. So that's what we know as the respiratory failure. But there can be other causes, like pulmonary embolism has been seen in many cases. It may be contributing, it may be the sole cause itself causing respiratory failure. So to help the respiratory failure, we can do many things. We can start from simple measure like positioning the patient, clearing the airway secretions, and then in the next step we have to start providing supplemental oxygen. Supplemental oxygen can be given in various forms through masks, and the masks have a variety of masks are available. The better ones are the Venturi masks, which start giving oxygen from 24%, 28, 35, 40, 60. And then we have a rebreathable mask, which can give up to 80% of oxygen. But when the respiratory failure, which we said that can be actually measured or diagnosed through the blood gases, but more simple than that, we can see whether there is a respiratory failure going on by measuring the oxygen saturation through a pulse oximeter on a finger. And that's more simple, most easily done, everywhere done. It's a part of the normal vital signs in the hospital to measure the oxygen levels. So when we measure the oxygen levels in a patient suffering from COVID illness, and when we see it is the saturations are 93% are going less with previously normal lungs, then we start thinking of respiratory failure. But if those people who have got already pre-existing lung diseases like COPD, interstitial lung disease, there our criteria would be different. Now, anyone who has less than 93, we have to monitor him very closely, and if it's not improving with supplemental oxygen, with increasing the concentration, increasing the flow, then we have to think of a ventilatory support. And here comes the role of the non-invasive ventilation. Now we need to understand here that what this means. You see, the invasive ventilation, the mechanical invasive ventilation, which is now so commonly being talked and which you all have seen in all over the world, is now I think in the last 3 months the maximum ventilation have been given to so many human beings on earth. So the invasiveness comes because we need an intubation. We need a tube to go through the mouth into the trachea, and that kind of procedure can only be done by experts who are not available everywhere. So even if we have ventilators available, we would not be able to start any ventilation anywhere because now there are places in the world where people have received donated ventilators, but they don't have the human resources available. So this the invasive ventilation means that we need intubation of the trachea, and we need an ICU setting. We need other associated requirements like arterial blood gases, infusion pumps, which means that it's not easy. So it's available in many places, in many countries, but in a developing country, the ventilators may be few, maybe not available in remote areas or in the rural areas, maybe only available in tertiary care centers. On the other hand, the non-invasive ventilatory support is very simple. Now, there is a CPAP, which means continuous positive airway pressure. So there is a CPAP machine, which means continuous positive airway pressure. And there is a BiPAP, which means bi-level positive airway pressure. The BiPAP is also called non-invasive ventilator. Now CPAP can also be included in the NIV, but commonly we call the BiPAP as NIV and CPAP as CPAP. These two non-invasive ventilators have been available for a long time, and we have been using CPAP in people who have got pulmonary edema and also in pneumonia. CPAP is commonly used for obstructive sleep apnea. So many people have got CPAPs in their homes, and they are able to use CPAPs themselves because they are easy. They just need a mask to fit in over their face, and then a tubing, and then a machine which can be kept on the bedside table. Similarly, the BiPAP, there is a little difference between CPAP and BiPAP. CPAP gives only one kind of pressure, continuous positive airway pressure, in the inspiratory phase, in breathing inside, while BiPAP gives two levels, which means that there is an IPAP, inspiratory positive airway pressure, as well as a expiratory positive airway pressure, EPAP. So BiPAP is usually required for those people where there is element of a hypercapnia, people who have got already COPD, but IPAP is usually for those who have got the CPAP is usually for those who have got simple hypoxemia or type 1 respiratory failure. However, of course, the expert doctors decide who are the patients who are going to need the ventilator support, and who are the ones who are going to need the non-invasive, and who are going to need the invasive. Now, trying to focus to our non-invasive ventilatory support, as I had mentioned that during the last few months, they were used in multiple places, starting from China. Then Italy were reluctant initially, but they also started using CPAPs. And then United Kingdom. So they have been found beneficial to a certain extent, with some limitations. However, there is still debate going on that how much they really benefit and whether they should be given or not. But from the available evidence, there is benefit in many situations, and we will discuss a bit later that what the evidence says. But what we need to understand here is that they are beneficial, and they are going to be more beneficial in those situations where the invasive ventilation is not available. So, but before going forward, we need to understand that we are not talking about non-invasive ventilation, saying that it's a substitute for invasive ventilation. No, it cannot be a substitute. So wherever there is a respiratory failure, there is a severe respiratory failure, and there is a clear indication for ventilatory support, the patient, the sufferer has to go onto a ventilator. But there are situations where we would not be able to do that. So that's why we are talking it, but not as a substitution, but as a help, as a bridge, and as a ceiling of care in many people. I would like to discuss a bit of evidence before going into the details of this CPAP and BiPAP. You see, the World Health Organization in March, in their guidelines about the management of COVID patients, especially severe pneumonia, had already told us that NIV, CPAP should be used in cases when and where indicated, before thinking of ventilatory support. But in some patients, you may directly go to ventilatory supports without these initial trials. Lancet, in their articles on 9th of April and 20th of April, this is the Lancet Respiratory, they said, quoting a study from China, where 130 patients had been studied, with this aim that what is the benefit of non-invasive ventilation. They found that there has been a good benefit, because many people improved on CPAP and did not require to go to the stage of ventilation. I'm talking of those who had mild respiratory failure, but there were many who worsened while on the CPAP, and they had to be finally taken to the ventilatory, to the invasive ventilation. Then we have a Canadian journal which published an article on 17th of April talking about the same experience of China, and giving a lot of examples, and they also came to the conclusion, yes, that NIV, non-invasive ventilation, should be used. So based on those few case series, few studies, and experiences from Italy, and local experiences of experts, the British Thoracic Society and NHS England, in their guidelines, they have recommended, and I think these guidelines were already there in end of March, but the updated one is from 6th or 7th of April. So they recommended, yes, CPAP and BiPAP can be used and should be used where they are indicated. Now we're going to talk where they would be indicated, because I'm just quoting these from the guideline. It says that escalation of ventilatory support, whether as a trial of treatment, as a ceiling of care, or as possible bridge to ongoing invasive ventilation, need to be made early and by experienced clinical decision makers. End quote. So you can see that the guidelines allows us to use them, but with vigilance, with precautions. Who are those groups of patients who can benefit from the non-invasive ventilation, CPAP and non-invasive ventilation? To add, I would say that most of the patients are on CPAPs, and there's only a need of a BiPAP when there is an element of hypercapnia, but for all hypoxemia, CPAP has worked well. So the group of patients who are likely to benefit, number one, are those patients who have got mild respiratory failure, oxygen saturations less than 93%, but around 90%, and they're not going down to lower 80s, and they're just 88, 89, 90, and the patient is not very unwell otherwise, and they are tolerating the CPAP, and we can keep them on CPAP by measuring their pulse oximetry and monitoring their other vital signs. If they show improvement, well and good, we can continue. But if they decline, if they during this period, or if the condition starts worsening, then we have to stop it and think of ventilatory support by involving ITU. The second group of patients is those who have a lot of comorbidity, and they are not candidates for ITU, and we have discussed with ITU, they would not be interested to take them. So this becomes the ceiling of care for those patients who are suffering from respiratory failure of any grade. But since this ceiling of care is only CPAP, so we will give them CPAP if they are having only hypoxemia, if they are having hypercapnia as well because of some underlying lung condition like COPD or obesity hyperventilation, we will give them BiPAP. And the third group of patients are those who really require invasive ventilation, but we do not have invasive ventilator available. There is no place in the ICU. So to bridge the time, we have to put them on a CPAP or a BiPAP, and we have to wait. As soon as possible, they can be taken to the ICU, or they can be taken to the ventilator support. Ideally, these kind of patients who would need immediate intubation and ventilation should be in the ICU or HDU, so that immediately they can be intubated if there is a deterioration, if there is a worsening. These are the three common groups. However, I would like to add a fourth one with a special context in my mind, and that is regions where there are no facilities for invasive ventilation. What we should do? Hospital doctors, they may receive very little number of patients from the community, because we all know that more than 80% would improve in the community, at a lower level, not requiring even the hospital. But those who come to the hospital, and from them having pneumonia, a small number would require ventilatory support. And if there is nothing available, we cannot say that we are living in a faraway, remote region. We will not be able to give, because there are some regions where you can shift patients to tertiary care hospital, but there are regions where it would be very difficult because of the long distances involved. So I would like to keep this fourth indication as well. Now, a bit of details of the CPAP. CPAP means continuous positive airway pressure. So there is a positive pressure going on during the inspiratory phase, and this positive pressure is meant for actually being conveyed to the alveoli. So this positive pressure means positive pressure in the alveoli, because normally at the beginning of the inspiration there would be a negative pressure in the alveoli, which would put them at risk of collapsing, especially in situation of the COVID, where the surfactant has gone down and the alveoli can collapse, and there is an exudate, there is an inflammatory material, so the oxygen is clearly not finding the way to get transferred to the blood through the respiratory membrane. In this situation, the CPAP, the positive airway pressure being conveyed to this machine, is going to be quite helpful. The BiPAP, which is a bi-level positive airway pressure, is needed in those patients who have got an element of hypercapnia, and they had probably underlying obesity hyperventilation or COPD. And in BiPAP there is not only a pressure during the inspiratory phase, which is called IPAP, but there is a pressure lower than the IPAP, lower than the inspiratory, in the expiratory phase as well. So this bi-level pressure both in inspiration and expiration. And this is the benefit of BiPAP, that it can wash out the carbon dioxide which the CPAP would not be able to do. And these both, as you should be aware, are otherwise used in the hospital settings and home settings for many patients, especially for those who got COPD and those who got obesity hyperventilation and those who got obstructive sleep apnea. So this is, you see, as I said in the beginning, something went mainly for administrators, because we want to sort of inform them, and because they have to make decisions regarding procuring these kind of machines. So we want to just inform them that what is the benefit of these kind of machines, these kind of devices, and they should be aware so they can take the right decisions. I will not go into the details, you see, that how these are going to work, and the technical side of them. I'm not going to show you, but that would need another video. I may show you some. This I can show you. This is how it looks like. This is you see, you can see this is just on the bedside. You can keep this small machine, and this is the tubing, and this is the face mask. The mask can be covering both nose and mouth, and there are some masks which can be only nasal masks, and one can apply filters here, proper filters, you see, to prevent infections, and filters can be applied on both sides as well. So there is a tubing. The machine is something used for many patients, one after the other, but tubing has to be changed. They're disposable, and I can show you another picture. You can see this is the CPAP, and this is the tubing, and this is the mask. The mask has to be tightly fitted, and this is kept on the bedside table. It's just a small one. One can you see, lift on one hand, and just if you have seen a nebulizer machine, it's something like size of that. And there is another photo of a CPAP, and the BiPAP looks like almost the same. So as I have said, that now we are going to talk a bit about the context of Gilgit-Baltistan, to which I belong, and this is a unique place on earth, a very special place with high mountain ranges, one of the highest mountain ranges in the world, with world's second highest peak, K2 being there, and some other 5 peaks which are among those peaks which are 8,000 meters. There are only 14 peaks in the world which are 8,000 meters, and among those 5 are in that region of Pakistan. We have got many glaciers, Balturo, Batura, and Siachen, and we have got a lot of lakes and beautiful valleys. So, but that beautiful, unique place is a bit remote in the mountains of Pakistan, and we are on the border of China, but the border is closed currently. So I know from my own experience being from there, and also from current knowledge from friends, that in Gilgit they were trying to set up an ICU with proper equipment, but so far they have not been probably able to do it fully. In Skardu, I heard that they have got ITU with ventilator facilities, and they've got 2 BiPAPs as well in Skardu. That's very nice to hear. But in Gilgit, I think the problem is that of a human resource, trained people are not available, although they have got donated ventilators available. But the problem is not the availability of ventilators. We have to have proper trained personnel, because as I said, I tried to explain that we need people who would intubate the patients when they are in stage of severe respiratory failure and severe hypoxemia. They will need intubation. That is the part where we need experts. Then we need arterial blood gas machines, infusion pumps, so many other things are required in an ICU. So best wishes and whatever we can do. Our colleagues have recently been to Gilgit and they have done their best to help them. You see, we have got colleagues from London who had gone to the Gilgit-Baltistan province, and they tried to help them in whatever way they could. But of course, the full-fledged ICU has not yet started, and that can take weeks or months. But that we hope that it should go very quickly, as soon as possible. So the CPAP or BiPAP is not a substitute for that kind of ICU. That is must. That should be started as soon as possible. But what I would like to explain is that until that is done, until we have a fully equipped ICU available, until our ventilators start running, what we should do if we are doctors in the hospital. I'm not talking of doctors or administrators, or not many public health people who are looking after most of the patients, majority of them in the community settings, in quarantines, in their villages. Of course, they have got a lot of contribution. Those who are distributing PPEs, they are distributing food and other stuff, and they are much appreciated, and they are doing a lot for those patients who are more than 90% in, I would say, in terms of Gilgit-Baltistan, because there has been a success story in Gilgit-Baltistan. The government has done many things very good. And so far, very few cases has reached to the stage of requiring a ventilation. Maybe I think one young doctor was placed on a ventilator. But in a post-lockdown situation, if we start getting more patients with respiratory failure, severe respiratory failure in our hospital, like a DHQ hospital Gilgit, what we should do? If I'm a doctor there, I can't say that our ventilators are still not working and you have to wait. I have to do something, because even if they are very less compared to the lot of patients being taken care in the community, for those few patients in the hospital who are going to come to the hospital, who are going to come to the our HDU, our ward, we need to do something. And I think that acquiring or procuring a couple of these CPAPs can bridge the gap, can help us, and we can at least give maybe some of them would improve. And yes, there can be some problems, like people have objected about the aerosol production. So yes, wherever CPAP is given, there is a risk that the patients may produce a lot of aerosol, and if they are COVID positive, they may produce to the surrounding and to the patient. So the requirement is they have to be in a separate side room with peripherally negative ventilation would not be available in a place like province of Gilgit-Baltistan. However, if there is a ventilation towards outside, not towards inside, that is fair enough. And the second most important thing is all those doctors, nursing staff, other auxiliary staff should be able to attend them in fully equipped PPE. That means they should have respirator N95 masks, because yes, in that room, because of the aerosol generated by the CPAP, there would be more chances of viruses in that environment. So that is must. But you see, that one reason should not deprive them. You see, if I'm a patient of COVID, which I recently suffered and recovered, fortunately, but if I had gone to that stage of respiratory failure, and if I was in Hunza or in Gilgit, and if I develop respiratory failure, and I'm told that sorry, we have nothing available to give you, that would be very, very, very difficult. A human problem. So I think this is not expensive. As I said, they are simple, they are portable, they are cheap, and they're easy to use. You can easily train the staff, the doctors, and as I explained again, I'm saying this again, that patients in many countries, even in Pakistan, are using these CPAPs in their homes for their obstructive sleep apnea. But the same simple CPAP machine is now proving, and the proof we have got, as I mentioned, many of those evidences. But on ground here in many hospitals of the United Kingdom, almost all hospitals in the United Kingdom are using CPAPs. Not that this country is a developed country and they've got a lot, but CPAP is cheap, is simple compared to a ventilator, which is an expensive machine and it's invasive. So with this, I would like to end the talk, and I hope I have been able to bring a bit of awareness about this non-invasive ventilation, about the benefit of the CPAP in respiratory failure related to COVID-19 and pneumonia, COVID-19 illness. Yes, colleagues may say that this is a very small element of people who are going to need it. I agree, I totally agree that much has to be done more in the community level, more at grassroots level. A lot of awareness needs to be brought in there, but that would not mean that those few, exceptionally few people who are going to require to come to the hospital, they cannot be deprived of a possible, potentially life-saving treatment which is available in the world, available in down country, in every hospital in Pakistan, so in all tertiary care hospitals. So I think our DHQs, at least our DHQ Gilgit, Skardu and some other DHQs can have a couple of these machines, CPAP machines, to use them when there is a need, and that would be really helpful. Thank you very much for listening.